Thank you. Thank you very much. And I have to spend a few seconds on the title, which is NIV in acute hypoxemic failure. And indeed, it's not acute de novo hypoxemic failure, but this is my potential conflict of interest in relationship to this presentation. Although I wish to remember that the guidelines produced by ERS ATS provide a high and strong recommendation for cardiogenic pulmonary edema, for and conditional recommendation for immunocompromised and preoperative and postoperative patients. I don't want to make an issue out of this because I think that the organizers wanted us to discuss about de novo acute respiratory failure. And so I hope you can appreciate I'm fair in this. And de novo acute respiratory failure, we did not provide any recommendation either in favor or against the use of NIV. Please note that in the same manner, we did not provide any recommendation for pandemic viral illness, something in the next few months might. So let's try to define what we mean by de novo acute respiratory failure. First of all, we are dealing with patients who are hypoxemic and not hypercapnic. The extent of hypoxemia is not defined, may vary from study to study, from conditions. So in this, my own definition, I use equal or less than 300 millimeters of mercury, no prior chronic disease, dyspnea and tachypnea during spontaneous and assisted breathing, and in general, 80 to 90% of patients have either pneumonia and or ARDS. So this is the type of patients we are dealing with, and according to a very, very old observational study run by Massimo Antonelli and a group of co-workers, this is the description of the use of non-invasive ventilation. The black square indicates the number of patients treated please 20 years ago, and on the left the failure rate indicated by the gray bars. If we draw a demarcation at 50% of failure rate, please note on the right, you see that the vast majority of patients is in, which means that according to this older data, more than half of patients would benefit of NIV, avoiding intubation, which is the failure rate here. But I'm pretty sure that Alexandre will present you two studies that play against the use of NIV. So in this case, it's better to show that you are bold at cutting your hair and not to try to cover with funny. So let's see the study by the subset study on NIV of the lung safe in Giacomo Bellani's first author. Roughly 15% of patients underwent in the first 24 or 48 hours NIV for RDS. And RDS was mild to moderate in nearly 80% of cases, as expected. And the rate of failure, please note the number, is 30%. And the rate of no failure, which is a funny way to say success, is 50%. And in 20% of cases, NIV was ceiling of treatment, so we don't really know what could happen. But let's take the 30% And we see that the percent of survivor is 55%, while the rate of surviving patients in intubated patients is 75% or near, which suggests that in these 71 patients who did not very well, the success rate was lower than in 1,337 patients intubated by scratch. But if we look at the lucky guys, 50% who did well, the rate of surviving patients was 84%, which exceeded the 74%, which indicate once more that if they do well, the outcome is better in NIV. And if they do bad, the outcome is going to be worse, which is nothing new, I guess. So the study doesn't really add anything new to our knowledge. Second study, the work by Jean-Pierre Frat, where the authors compare 3 forms of treatment for acute de novo hypoxemic respiratory failure: NIV, standard oxygen, and high flow oxygen. And please note that according to the main objective of the study, which is the one on which the study was powered, no difference between the 3. Which is kind of surprising, and because standard oxygen, I would think, but I was probably wrong, should perform less well than NIV and high flow oxygen therapy. Anyway, the study is negative, no difference. But this is the Kaplan-Meier that has been shown as potentially indicating an effect. In fact, at 90 days, there was a reduced rate of mortality in patients treated with high flow as opposed to NIV and standard oxygen. But after that study, 3 years other studies have indicated this aspect, and the results are completely different. And in this initial, partial, whatsoever meta-analysis by Rockwell and co-worker, there is no effect on mortality of high-flow oxygen therapy. So the results of the post-hoc analysis in the group by Frat was not confirmed. May happen because that is a post-hoc analysis, is not. But there is a strong physiopathological rationale. I mean, this is undoubtful. If you apply NIV to certain subgroups of hypoxemic patients, you may end up in this vicious circle, the so-called patient self-inflicted lung injury, which means that patients are utilizing the additional pressure provided by the ventilator to increase the tidal volume, because the neural drive is not regulated anymore by chemical stimuli, PCO2, but by other forms, which may be from the lung, from the chest wall, I mean, J receptor, whatsoever. It is no longer chemoregulated. And this is the explanation. Briefly, if this is the patient spontaneously breathing, and we say that the patient is sucking -20 of pleural pressure, and when we add the NIV on top of that, the pleural pressure remains the same, and the additional pressure, which is generating more volume, may result in injurious transpulmonary pressure. This is the concept, and this is a real hazard. This is something we should bear in mind. On the other side, however, there are conditions where if you need to recruit lung volume, you need to apply pressure. I would suggest positive and expiratory pressure mainly. I would probably use CPAP, but whatever. You need pressure. And the fact that not all the patients behave like the self-inflicted lung injury model is shown in this nice study by Erwan Ler and Laurent Brochard, who compared spontaneous breathing and with CPAP and pressure support, and showed that applying PEEP and pressure support, the inspiratory effort was reduced, indicating that in these specific patients and in this group mean data from that group of patients, NIV was able to reduce the effort and to ameliorate PaO2 and probably not increasing volume and transpulmonary pressure, which suggests that there are different phenotypes of acute hypoxemic de novo respiratory failure. And also the famous study by Yoshida, you know what? I think that all the studies I presented so far, I was one of the reviewers for the journal, so it's my responsibility. The work by Yoshida, he shows that in severe hypoxemic respiratory failure induced in animal, maintaining the spontaneous breathing was generating trouble, but in the less severe, actually, the results were improved when maintaining spontaneous breathing and providing ventilator support, as opposed to maintaining the patient in spontaneous breathing period. Quite the opposite, using the same approach in the most severe resulted in severe lung injury. So, other point, when we say NIV, we should define, technically speaking, what we are doing. This is the work by the group in Chicago, Patel, who suggests that different interfaces, in this case the helmet, might perform differently. This was better outcome with the helmet as opposed to the full face mask. But these are the two last slides, and this is the last published few days ago by the group of Massimo Antonelli in Rome, few patients, 15, and they compare standard oxygen through a mask with high flow nasal cannula with NIV through the helmet. And you see that there is a clear improvement in oxygenation with the helmet. The PCO2 remained unchanged. The respiratory rate was slightly and not significant, and though significantly reduced with the helmet, and the dyspnea was significantly improved by NIV by helmet. But this does not mean really anything, because it might result that these improvements are paid by an increased transpulmonary pressure. In the study, Luca Greco and co-worker used the esophageal pressure for assessing this point, and you see in all patients NIV decreased the pleural or esophageal pressure, indicating the reduction in effort. But when it comes to transpulmonary pressure, which is the concept we want to stay well focused on, there were no differences. And look at this. In some patients decreased, but in some patients increased, suggesting that there is a broad variability among patients. And some of these patients could have been harmed by the application of NIV, probably, and the vast majority probably don't. So the bottom line is that, in my opinion today, we know that some patients benefit and some do not of NIV, and the questions are, what is the rate of harmed patients and how do we recognize them? And I wish to thank you for your attention.